Okay. Good morning, my dear French colleague, and good afternoon to our Chinese colleague. First of all, I would like to thank the organizer of this Franco-Japanese Symposium to invite me and to let me the chance to talk about my research project on leukemogenesis in children. As Carine told you, my name is Carine DOMENECH, and I'm a pediatric physician for children when I take care for children with leukemia, and I perform research on leukemogenesis. Attends, il me voit. Okay, sorry. First of all, you have to know that acute lymphoblastic leukemia represents the first cause of cancer in children and teenagers. And whereas in adult leukemia are mostly developed on myeloid lineage, in children, leukemia are essentially due to the lymphoid lineage in 80% of cases. This leukemia, almost be acute lymphoblastic leukemia, arrive in very young children with a peak of incidence between 2 and 5 years and occurs more frequently in previously healthy children. As you probably know, in the bone marrow of healthy persons like you and me, we found hematopoietic stem cells that differentiate in hematopoietic progenitors and to give rise to hematopoietic cells such as red cells, white cells, and platelets. And then appear leukemic cells, also called blast cells, that will proliferate and invade totally the bone marrow and be responsible for leukemia. So our research projects have many objectives to understand how the leukemia cells appear, and we work on that on leukemogenesis, how the leukemia cell escape apoptosis, and what is the role of the microenvironment, of the bone marrow microenvironment in this mechanism to resistance to apoptosis. And we hope this answer, we will be able to cure more children thanks to the development of new treatment. And we hope also with treatment, directed treatment and with less toxicities. What do we learn about previously research projects? First of all, we know that some leukemic cells have intrinsic mechanisms resistant to apoptosis. For example, we know in clinic that some patients, approximately 10% of patients with B acute lymphoblastic leukemia, have a deletion of IKZF, also known Icaros gene. And these deletions are responsible for a decrease of the overall survival. In research, we understand why. Because when we delete this Icaros gene, we have an increase of cyclin D, and CDK4 and CDK6, and we lost the inhibitor of cell cycle. So we have a loss of the cell cycle regulation when there is a deletion of IKZF and apoptosis resistance mechanisms. But we also have to remember that the leukemic cells are in a microenvironment in the bone marrow, also called the niche, where we will find the leukemic cells, but we'll also find the mesenchymatous stem cells. And we also found lymphocytes such as natural killer cells and lymphocyte T cells. And we know, for now, that there exist some resistance mechanisms to apoptosis, like the tolerance of the immune system, when, for example, the blast cell will be able to immunoedit their cluster of differentiation, and they will modify their surface antigen to escape T lymphocyte, and will be able to proliferate even if as we see in the previous slide, there is T lymphocyte and natural killer in the microenvironment. And this immunoediting is now, we use these immunoediting mechanisms to develop new strategies, new therapeutic strategies such as immunotherapy. For example, we use blinatumomab, which is a B-specific antibody that will be able to reproach blast cell and T lymphocyte. Or we, of course, developed genic therapies such as CAR T cells for T cell will be able to recognize again blast cell and destruct it. So in our research project, we worked on patients hospitalized in our unit with children and teenagers from 1 year to 18 years. We work with patients that have B acute lymphoblastic leukemia in first line or at relapse. On the medullary sample, we perform at diagnosis or at relapse after obtention of signed parental consent, of course. So when we receive the new patient, we perform myelogram, which is bone marrow aspiration at diagnosis or at sample. And we take sample for the diagnosis and for the research. Then we perform a fecal plaque density-based cell separation to obtain medullary mononuclear cells that we use French if possible, or that we froze to use after. What we do with this MMC, this is medullary mononuclear cells. We took these cells to perform cell sortings on cytometry sorted cells, and we sort leukemic cells to perform RNA extraction, and we will perform RNA sequencing in Paris in 1 at 2 months. That will allow us to obtain, we hope, to analyze the expression of genes that could be involved in leukemogenesis, to search for new prognosis factors, and to identify of new therapeutic targets. When what we do when we sort blast cell, as you can see on this slide, we have the cell on cytometry, all the cells. We choose, of course, the cells alive, and it's frequently difficult when we have frozen cells because blast cells are are dying very quickly. So we have to work very, very quickly too. And we select, as you can see on this slide, the CD45 low cells because the B blast cell have the particularity to express a low pan-hematopoietic cluster of differentiation 45. And then we select the leukemic cell according to the immunophenotype. For example, here, the CD90 cluster of differentiation. And we also have the patient characteristic that will with sequence. And as you can see on this slide, we have a very beautiful panel of patients, more representative of what we could observe in practice of every day for the patient with BHAL. We have young patients, we have teenagers, we have some patients with monosomy 5, with hyperdiploidy, with translocation 12, 21, etc. And we hope we will have good results with the RNA sequencing. But when we sort medullary mononuclear cells, we also try to study the residual bone marrow functionality, if it exists, of course. For that, we sort in the same time that blast cell, the residual hematopoietic stem cell based on the expression of the pan-hematopoietic cluster of differentiation 45 and based on the cluster of differentiation 34, sorry, and 38. And when we record this cell, if they exist, we put them in co-culture with MS5 that are mesenchymatous stem cells issued from mouse bone marrow to put hematopoietic stem cell on it with interleukin, with cocktail of interleukin. And at G14, sorry, we take back the cells for cytometry analysis to see if this hematopoietic stem cell residual are able to produce myeloid cells, such granulocyte or monocyte, but also lymphocyte cells, such as natural killer or B lymphocyte. On this slide, you can see the result on D14 with the MS5 here, and the differentiated hematopoietic cells here that we harvest. And we put that on the cytometry analysis with a cluster of differentiation from monocyte, natural killer, B lymphocyte. And then we analyze for each patient the residual hematopoietic functionality. And we observe that for almost every patient, we have natural killer produced. And for some patients, we have B lymphocytes non-sick for some of them, and we are actually analyze the result for approximately 40 patients. To finish, we also focus on the microenvironment of this B acute lymphoblastic leukemia. And after perform the fecal technique, we put the mesenchymatous stem cell from patient in culture. And this part was very hard because MSC from B acute lymphoblastic leukemia are very hard to put in culture. But now we arrived with this result. And actually, we characterize this mesenchymatous stem cell from different patients, and we characterize the cell growth rate because it is very, very different between patients. And we try to rely this characterized with type of B acute lymphoblastic leukemia, the age of patient, etc. We also take pictures to characterize the morphological appearance. We perform cloning formation unit. We immunophenotype the cell. We test the capacity of differentiation, and we also perform RNA sequencing on these cells. And after, we actually try to put some co-culture systems with patient mesenchymatous stem cells and with hematopoietic stem cell control of patient of controls of, this is to say, of children and teenagers without leukemia. And we perform also co-culture system with blast cells with mesenchymatous stem cell from control, this is to say, patient without acute lymphoblastic leukemia. And we will try to study the cellular influence of hematopoietic cell and mesenchymatous stem cells from patients and from control. We also study the secretum between the two types of cell, and to finish, we will perform drug testing. Actually, we already had a new potential target with Netrin-1 and Neogenine. What scientific background told us? We know actually that Netrin-1 and its dependence receptor Neogenin-1 are fundamental in the cations of adult hematopoietic stem cells. We also know that this couple of ligand, Netrin-1 and this dependence receptor, are very expressed highly in fetal hematopoietic stem cells. And we know that Netrin-1 is implicated in many cancers, including children cancer. When of this ligand function, this is dependence receptor, and this is a ligand that will induce differentiation, proliferation and migration of the cell. And when the ligand go away, this dependent receptor will induce apoptosis. But in many cancers, the cancer cell produce more ligands that will induce tumor proliferation, migration, and will be a mechanism resistance from apoptosis. And in our acute lymphoblastic leukemia, we already show that there exists an overexpression of Netrin-1 and of its ligand neogenid in the BHAL with a poor prognosis. And we will ask if this Netrin-1 and its ligand could be a new prognostic factor and maybe a new therapeutic target in acute lymphoblastic leukemia with a poor prognosis. So, in conclusion and for the perspective, we, after the RNA sequencing and the study of the hematopoietic stem cell functionality for when residual cells are present, we focus essentially on the development of co-culture system that should allow us, we hope, a better understanding of the implication of mesenchymatous stem cells in apoptosis resistance mechanism of leukemic cell, but also to study the secretum and possibly highlight the involvement of some key proteins in the communication between blast and MSC, allow blast mechanism resistance to apoptosis, and to carry out drug testing on leukemic cells on their supportive physiological cells. And if French and our Chinese colleagues have some expertise on the co-culture system, or if you know how to study more precisely the implication of the microenvironment in the development of cancer disease, it will be, of course, a pleasure for us to collaborate with you on this project. To finish, we will also work on the involvement of Netrin-1 in leukemogenesis, in particular the involvement of Netrin-1 in leukemic stem cells, and we will try to study the mechanism of resistance to apoptosis implemented in this leukemia, and if it will be a prognostic factor. And we'll also try to study of an antibody anti-Netrin-1 could help us to have better results in vitro, of course, for and in mouse, of course, for first in acute leukemia, acute lymphoblastic leukemia of poor prognosis. So to finish, I'd like to thank Dr. Michel Souris that worked on me on this project, Sarah Blanc, with his very, very precious help, and my student Erivan and Thomas that work on me on this study. Of course, I would like to thank all the sponsors and of course the CLARA. Thank you for your attention.
Thank you very much for this talk, Carine. It's a very nice talk. I am not very expert in this field, but actually you are talking about proliferation, and I was wondering what is the contribution of senescence in this pathology. Do you have any idea about that?
The children are very interesting because the mechanism, the senescence mechanism is different. Actually, I don't think it's a study because in children, contrary to the adults, as I told in the first slide, in adults, we observe essentially myeloid leukemia because when the children grow up, in teenager and in adults, there is a more production of myeloid lymphoid lineage. And actually, I know numerous of teams that work on this mechanism to know if there is a senescent system that put on the myeloid lineage in adults or other things. And in children, there is a lot production of lymphoid lineage during the fetal life and during the in children, and less and less in the teenagers, because there is a lot of productions of cell, in particular lymphoid cells. And I think it's why we also observe essentially acute lymphoblastic leukemia in children, but we don't know exactly if senescence mechanism, is implicated in the apparition of leukemia, acute lymphoblastic leukemia in children.
Okay, thank you. Is
You're
there
welcome.
any question from the audience, or I don't see anything for the moment?
No question on the chat for now.
Okay.
I have
Dr.
first
Phil.
question.
Go ahead.
Yeah, you primarily talk about the nutrient one, right? If I am not wrong, so most of the studies in the literature are nutrient 4. So is the nutrient 4 expressed in your leukemic cells or in HSC?
Yeah, it's very good question. As you know, the nitrogen 1 is essentially described until now in solid cancer, but also in lymphoma and B lymphoma in adult patients. Recently, there was a work from Trump team. This is a big team that work on hematopoietic stem cell that show that nitrogen 1 and its ligand neogenin have an important role in the quiescence of hematopoietic stem cell. And when we look for this expression in our B acute lymphoblastic leukemia, we show that there is, as I told you, a big expression, high expression of nitrogen in its ligand in the B acute lymphoblastic leukemia of worse prognosis, but not in the B acute lymphoblastic leukemia of good prognosis. And we also work on fetal life. I don't have the time to speak about that now, but we work on that with good collaboration with units in Saint-Louis Hospital in Paris. And we saw that in hematopoietic stem cells during the fetal life, there is a very, very high expression of nitrogen 1 and its ligand that disappear in children, in healthy children. But we observe a higher expression when children have a B acute lymphoblastic leukemia of worse prognosis. So we look for this investigation with the RNA sequencing, and we also perform a PDX mouse model that we will treat if there is a higher expression of nitrogen 1 with antibody directed again against nitrogen 1 to look for there is less leukemia.
Okay, thank you.
You're welcome.
I have another question,
Yeah.
Carine. I know that you are talking about the involvement of nitrogen in eventually in the proliferation. That it's very well described, and but you talk about the involvement of nitrogen in cell migration. So, do you know the mechanism which involved the nitrogen in cell migration? How does it work? Does it have any connection with integrin or something like that?
I'm sorry, I won't be able to respond to this because, like in the leukemia, we don't really work on migrations of cells, and I am essentially focused on the apoptosis resistance mechanism in leukemia cell, but not in the migration of cells. And I'm not sure my response will be fine. So.
Yeah.
I don't.
But actually, you should expect very nice cues in your secretome analysis. Actually.
Yeah. Yes.
I guess
think. Yeah.
You can maybe expect the identity of some chemokine or some, or maybe some protein involved in extracellular matrix environment.
Yeah.
And I think it's a good idea to do that.
Yeah, thank you. But yes, we expect effectively that.
Okay.
That's what we would try to perform.
Is there anybody else who would like to ask a question? I'm looking at the chat.
Hi, Dr. Hoff. I have one simple question.
Yeah.
Yeah. So it's a very interesting study. So I think you mentioned you use the mesenchymal stem cell for the co-culture study.
Yeah.
Do you think is there any other type of microenvironmental cells like endothelial cells or some other type of cells also involved in the leukemia in your study? So why you only choose the mesenchymal stem cells for your study? So any comments for this?
To choose the stem cells from patients? I'm sorry, there is acute in your question. I don't hear of the question. Sorry.
Okay, yeah, I mean, why you only choose the mesenchymal stem cells for the co-culture system? Maybe you also should use some other type of niche cells like endothelial cells for co-culture study, and then to test what happened to leukemiogenesis. So why you only choose the mesenchymal? So
for co-culture system. Okay, I understand your question. We choose to try the co-culture system with mesenchymal stem cells. First, because we already had a project with Paris on the study of mesenchymal stem cells during the ontogenic life and on the disease in elder patients. And we already see and so that there is a relation between hematopoietic disease and the collaborative communication with the mesenchymal stem cells. And personally, I am also, a physician that treats a patient with leukemia. I'm totally sure that there is an implication of the mesenchymal stem cells in the mechanisms of resistance of apoptosis from some B acute lymphoblastic leukemia. For example, when we had patients with no bad prognosis factor that relapse again and again, and even after we grafted them, I think there is a role, an implication of the bone marrow stem cell, mesenchymal stem cell. That's why we choose to perform this study. However, it is also difficult to have a good co-culture system with blast cells that die very quickly and to put this cell. So now we almost arrived to obtain good results, and we focus on that for now, but you are totally right. And after, probably we have to put another cells to more study the relationship, the interlink between the blast cell and the microenvironment.
okay, thank you.
You're welcome.
Thank you. Anybody else? Okay. So thank you very much, Carine.
Thank you.